Good afternoon, ladies and gentlemen. Welcome to today's webcast titled The Advantages of Aligning Case Management with Revenue Cycle. If you would like to submit a question to our presenters during this webinar, we encourage you to use the questions/chat feature in your webinar browser. Our presenters will address submitted questions and comments at the end of today's webinar. At this time, it is my pleasure to introduce Mary Devine, Senior Director of Revenue Cycle at Bessler, and Meliza Weiner, Manager and Clinical Review Nurse at Bessler. Mary, the floor is all yours.
Thank you, Tom. So today, Meliza and I are going to be presenting on the advantages of aligning case management with revenue cycle. And when Meliza and I sat down and started to put this together, we really thought that it was perfect for the both of us because we have very similar yet very different backgrounds. I started with an accounting degree and was working with hospitals on their reimbursement, and quite often would sit down with the clinical staff and have arguments that I didn't understand what the clinical side was really like. So at that point, I made the decision to go back to school and get my RN and worked on some nursing floors so I could get that practical experience, but ended up continuing on in the healthcare reimbursement world. And Meliza, why don't you tell a little bit about your background?
All right, thank you, Mary. Just like Mary said, I actually started on the opposite end of how Mary started. I started basically with a degree in nursing, and to Mary's point, I sat in a lot of operations meeting and director meetings, and the finance people will be on the other end of the table, and they will be saying things and using terms that I feel like was over my head, and I don't understand where that's coming from and how that ties into money. So I decided to pursue my degree in business and finance to understand that aspect in order to put two and two together. So like Mary pointed out, it's one of those things that we need to understand both sides in order to merge the two.
So, and I think back to when I was getting back into the finance world after I had my RN and was working as an RN for a bit. I really felt that being an accounting background in RN was a wow factor. And now it really isn't. There's many, many people, we're almost a dime a dozen, and it really shows the blending of the two worlds of revenue cycle and the clinical world. So as we set out to put this presentation together, one of the things that we thought was really important was to go out and get some opinions of the industry, both from a revenue cycle perspective as well as the case management clinical perspective. So Meliza first, she went out and she spoke to some of her clinical resources. Meliza, why don't you tell them what you found out?
Right. So physician advisors are one of those that a lot of the healthcare industries are using right now. And I did speak with some physician advisors, and I asked them about what do they think about the aligning of case management and revenue cycle. Well, physician advisors, they 100% totally agree. Case management belongs with revenue cycle. So then I said, okay, there are other people involved in this one. So I started talking to case managers. They don't agree. They said that the reporting structure should stay the same where it is, but they know that there needs to be some involvement. Management, on the other hand, say it's 50-50. They understand that it makes sense, but they just want to make sure that it's not just about the money and not forget about the patient. And then, of course, you have your physician. You have to involve the physician because they are the captain of the ship. They believe that case management should report to the medical office, as it should be. So to them, it's all about the patient, and they should report to them. And I believe Mary went back to her area of expertise in revenue cycle and gathered their opinion.
Yep, absolutely. So in speaking with someone who is responsible for the revenue cycle in their facility, one of them said that she felt that was imperative that case management and UR and care management are all aligned with revenue cycle. If there's not that alignment, denials are difficult, if not impossible, to overturn and trend and make any necessary corrections. So you need that alignment in order for to improve things. And then there was someone else who said they thought it makes sense in our arena to capture as much revenue and protect as much as you can. And the clinical area and the revenue cycle are critical to making that happen. So in the polls that I took, they were definitely for the alignment. So just some of the things that we're going to cover together, we're going to first get through some objectives, and then we're going to discuss the regulatory requirements. We're going to talk about how case management impacts revenue cycle and vice versa, how revenue cycle impacts case management. We'll talk about some of the benefits of aligning the two departments, and then leave just a few takeaways with you. And on November 29th of 2019, the new discharge planning requirements came out, and we are certainly going to touch on those throughout the presentation. As we look at the objectives that we'd like to accomplish through our presentation, we're going to talk about reasons for updating the reporting structure for case management, the pros and cons of aligning patient care management and finance, examples supporting the case for aligning desired outcomes and financial results, and then finally, there'll be some key strategies for coordinating case management and revenue cycle. You know, and as much as we like to be interactive, it takes a little bit of pressure off of us. We're going to hold all the questions to the end, so just if you have one, please type it in, and then we will review them at the end. I do want to mention that we have a lot to cover, and we're going to make sure that you guys only get your money's worth with this. I know that most of you are probably on your lunch hour, so we're going to do everything we can to wrap up at 2 o'clock sharp. Increasing patient liabilities and consumerism is demanding a complete transformation of the revenue cycle. So when I say that, it makes me think of buying a car today. You know, when you go out and you buy a car today, you don't walk in there blind. You know exactly what kind of car you're looking for, how much you're going to be willing to pay for it, and the options that you want it to have. Well, I think with the rising patient liabilities in healthcare, I think healthcare is really becoming more and more like that, because patients are having to pay more and more for their healthcare, and they want to make sure they understand exactly what type of procedures they're going to be having. Matter of fact, you know, with the internet, people are shopping around for the best provider in the procedure that they're getting done, and they want to know how much they're going to spend. So definitely, I think that consumerism is taking hold in the healthcare world, and we'll mention it quite a few times throughout our presentation. So first I want to talk about the regulatory requirements from a billing perspective, and not knowing what everybody's background, but I'm pretty sure this is going to be a quick review for everyone. So, you know, claims must accurately reflect what is documented in the chart. It goes back to that old verbiage, if it's not documented, it didn't happen. Coding requirements vary by payer, and this certainly complicates things and getting them appropriately fit on the bill. So, you know, Medicare and Medicaid certainly have different coding requirements, and then your commercial payers, depending on how they want it billed or how they're going to reimburse you, they want it coded a little differently. Claims should reflect the actual care being provided from the perspective of procedures, making sure the diagnosis codes are on there to support the procedures. The admit and discharge dates are appropriate versus when the patient first got to the hospital. And then you want to make sure that the appropriate providers that perform the services are actually reflected on that claim. And this sounds simple and repetitive, but to be honest with you, you know, people fight to do this right on a daily basis. And, you know, it's a focus for many, many years, but it's still a struggle with hospitals. And claims, you want the claims to reflect where the patient is going from a discharge status perspective, or you could impact reimbursement. And patient responsibility and awareness is a big one. They want to know what's going on and make sure that they're aware of what's happening to them and what they're going to owe. So there's certainly billing implications that go along with things that aren't correct. You're going to be faced with rejections and or denials. Certainly, reduction in reimbursement is a downfall of some of these errors that could occur. Or you could be overpaid, and overpaid is no better than having a reduced reimbursement. You could be sending in false claims. There might be lawsuits, and certainly patient dissatisfaction. And when you talk about the consumerism, patient dissatisfaction is a big thing. And Meliza is going to talk about case management.
All right, thank you, Mary. So case management, I guess before we start, we just want to make sure that we understand what case management is, and I think a lot of you guys are familiar with it, but I just want to go over a few things, should we say a case management 101. So we want to define case management because given the diversity of settings and the case management models out there and organizational idiosyncrasies, case management roles tend to be noted as vague, and sometimes it's overgeneralized and feel like it's a one-size-fits-all. But there are numerous studies attempting to define the roles and responsibility and basically the essential functions of case management. By definition, there are two associations that is very familiar with case management, the Case Management Society of America and the American Case Management Association. Now, I'm going to read you the definition. It might be a little wordy, but I'm going to do the best that I can just to basically cut it down. The Case Management Society of America basically states that case management is a collaborative process of assessment, planning, facilitation, and care coordination, and evaluation and advocacy for options and services. They promote patient safety, quality of care, and cost-effective outcomes. Where the Association of Case Management, they actually state that it's a collaborative practice model. It encompasses in communication and facilitates care along the continuum through effective resource coordination. So basically, both associations defines case management as a concerted methodology. They use the word collaborative. It is a process and it's a model, and the focus is continuum of care transition. Now, utilization management is another term that's sometimes being interchanged with case management. So utilization management, by definition of the CMSA, the Case Management Society of America, states that it ensures the appropriate allocation, use, and coordination of healthcare services and resources while maintaining cost effectiveness. The association, the American Case Management Association, defines it as advocacy for the patient while balancing the responsibility of stewardship for their organization and the judicial management of resources. Now, in essence, really, utilization management encompasses a diverse set and group of techniques and activities. They are designed to influence the use of healthcare resources and basically constraining healthcare resource consumption. So the focus of utilization management is cost containment and cost management. So now you're going to say, okay, Meliza, what's the point? Okay, well, the point is there a difference between case management and utilization management? There is an answer to both. It's actually yes and no. There's the difference. Technically and literally, yes, by definition, the purpose, the focus, the responsibility, it is different. However, there's a no aspect to that. Despite the cost management focus of utilization management and the continuum of care transition focus of case management, they both have overlapping responsibility. They incorporate quality patient care, they affect the healthcare continuum and transition, and they impact revenue cycle.
And Meliza, I'll talk about that a few slides ahead.
Yep. Regulatory requirements. Mary mentioned the regulatory requirements about revenue cycle. There are regulatory requirements for case management. So case management are licensed professionals who are obligated to work within the ethical, legal, and practice standards. Their role is protecting the rights and dignity and the interests of the clients. They have to follow organizational compliance and policy. And the one thing that they also have to keep in mind is that the payors and the health plans, those contracts, they need to abide by those contracts. Sometimes those little fine lines in the bottom that nobody understands, that sometimes is going to affect determination and your denied days and ultimately affect your cash flow. Now, there are other regulatory requirements, which is very important, is federal. The Centers for Medicare and Medicaid Services, I think everybody's familiar with that one, CMS. All healthcare facilities that receive Medicare and Medicaid funds must follow the rules and regulations, such as your conditions of participation, your IPPS rules, your OPPS rules. You know, you provide required services, but you have to provide it within the law. In fact, in the conditions of participation, they note the formation, and you have to have a utilization management committee. You have to bill your services as required by the policy, and you need to treat all Medicare and Medicaid beneficiaries as referenced by law. You have to offer them choices. If not, it's going to affect your revenue. Social Security Act, That's the one, if 1861, I believe. It's about 51 pages, if you're familiar reading it. I know I don't remember every single page, but in essence, it states that a hospital should have, in effect, a UR plan. And if you go further, it's going to specify how a UR is supposed to be planned and how you're supposed to carry it out. I believe it's section E6A and 6B. And then Mary mentioned about the law that just got passed in November 29 of last year. She will go into details with that later on in the presentation, but in essence, really, CMS issued that law that takes into effect of last year that there should be active involvement by the patient in discharge planning, and that the hospital is required to provide information about those post-acute care facilities and the quality measures, not just giving them a list of names. And Mary's going to go into details about that later on, but if you want to read up on it, it's about 102 pages, so feel free. I also want to mention the state regulatory agencies. Medicaid is one of them. Now, it varies from state to state, one of which in New Jersey, I know you are familiar with the universal transfer form that's required, that needs to be filled out when you move patients from one facility to another. And then the other thing that I think some people forget, because the case managers are licensed, whether they are nurses or social workers, they have to follow their own laws, and with nursing, they have to follow the Nurse Practice Act and make sure they're not in violation of that. There are also the agencies, such as Joint Commission, that does the accreditations for your healthcare facility that needs to be followed. Another thing that I think is one slide of Mary's that she mentioned that impacts revenue cycle case management implications is the billing. Denials, length of stay, coding, they affect those. Risk and compliance, they have indication as far as whether we are in compliance with the rules and regulations and all of those audits, because ultimately it can affect your licensure, your certifications, as well as any accreditations. You don't want it revoked if you have it. And then going back to what Mary was mentioning about consumerism, stakeholder satisfaction and loyalty. Your payors, your physicians, you have to ensure that you still have their satisfaction and loyalty, providing that you are following everything within the guidelines and the rules. Now, I know Mary is going to talk more about how case management impacts revenue cycle, so I'm going to turn the presentation over to Mary.
Thank you. So, as Meliza mentioned, I'm going to be talking about the impacts on revenue cycle, and I think once I get through this, what you're really going to hear is we need case management involved in the revenue cycle, or we can't do it as good as we should. So denials, there's always going to be denials that clinical resources need to be involved in. When you think about day denials and level of care, they have to fight those at the time it's occurring concurrently, and you can't wait till after the claim was submitted and denied. Otherwise, you're going to get into costly appeals, and certainly case management would need to be involved with that. What these denials and appeals do, they cause payment delays. And there's also risk of incorrect coding, because the days or the level of care was communicated and the claims went out incorrectly. There might be mischarges. And then ultimately, we're going to have dissatisfied patients because they're going to be aware of the fact that you're appealing their stay, or it wasn't paid for. They're at risk of getting a claim and a cost of the bill that they were not counting on. So clinical documentation. Clinical documentation does not occur without the involvement of case management and UR, and certainly your physicians. So clinical documentation must be accurate and complete documentation, or it's going to impact payments. Coding and charging can be inaccurate, as we mentioned on the previous slide, and it impacts both the physician and the provider coding. Maybe you're only used to billing the provider claim, but it's going to impact your physician claim as well. So you want to make sure that's accurate. The fully documented patient's care needs to be there. And by this, I speak of including the patient outcomes. I think a lot of times that gets left out, and then some of the medical necessity is missed. And you know, the fact that they were there for 3 days versus 2 days, and what the outcomes were, so you can identify the needs of that patient and why them being there was important to their overall care. And then that ultimately is going to improve the revenue cycle because it's going to reduce denials and there's going to be reduced mischarges. %76% of hospital executives report denials as their biggest revenue challenge. And if you really think about the revenue cycle, you know, a lot of everybody's time is spent on that 25% of those claims that didn't pay when you first sent them out the door. So in order to make that less of a burden and getting the claims paid up front, the communication between finance and clinicians is critical to improve this. There has to be appropriate charge capture and clinical improvements as the overall goal. Clinicians are often in the dark on denials received for services. And you want to make sure that things are communicated to them, that if there is a denied day or if there is a denied level of care, that gets communicated and you work on making things better. And appeals are much more costly than getting it correct the first time. Then submitting that claim and having it pay appropriately and making sure that your contractual allowance and the way that the reimbursement is coming in matches what you thought it should be. You know, and there's a real there's a lot to be said about the time value of money and the need to trace it down. CDI has been a focus for years now. This is not new. Clinical documentation integrity, there's been a real focus, and the quality of the documentation impacts the quality of the bill and ultimately the quality of the reimbursement. And that's why there was so much focus on it from a hospital leadership perspective. And I think, you know, CDI might fall under revenue cycle in many places, but it's still under some of the clinical areas. And really what that's doing is it's making sure that the complete patient care is documented and it's actual care provided, and then it's focused on the outcomes of the patient, and ultimately you're going to see the patient outcomes are in fact increased. And again, the end result is that the billing is going to be accurate. Sorry about that. So just a few things on the incorrect coding. You know, again, there has been a lot of focus on this in years past, and there still is today. And the reason that is because coding impacts all aspects of reimbursement. Either you're going to be faced with denials because the appropriate coding isn't on there, or you're going to be faced with missed reimbursement because the codes aren't on there. So, you know, you're at risk for underpayments and overpayments, and both are equally not appropriate. And so you're going to have improper charging, improper coding, then there's going to be revenue integrity at question, and then you also want to make sure that your discharge status codes are appropriate. So again, because that's going to impact your reimbursement, you might get paid the per diem where you are actually due the full DRG, or again, vice versa. And you want to make sure that case management is involved right from the point where that patient gets scheduled. So from a pre-admission perspective, you want to make sure that they're involved and you understand whether that patient should be an outpatient or an inpatient. And I think Meliza can attest to the need for case management to be involved from the point of scheduling.
Correct. You know, going back then, I remember that the focus was length of stay and moving the patient and getting the discharge planning to happen, not realizing that you have to get it at the front end. If you start the discharge planning on day one and you are working already on the discharge planning, then you know when it's time for the patient to be discharged that you already have a plan in place and you have all the key players involved. So it's very easy to pull and move case management from the front end and put them in the back end because you're running out of beds, should we say. And so you want to move. But if you get them right at the first time at the beginning, you won't have that downward effect where you are just catching up, like Mary puts it. You know, once the bill is out, now you're getting rejection and denials. Now it's trying to push, and now you're trying to circle back and try to fix what happened on the front end.
Classifying the patients as inpatient, outpatient, or observation impacts 100% of the billing process, even in some cases where the claim form is slightly different, and certainly the coding would be different. So you want to get that right from the get-go. If a patient was admitted and they downgraded to an outpatient, that wasn't communicated appropriately and the bill went out wrong, again, you're stuck tracing down that claim. And it will cause delays and denials, and certainly if they weren't involved at the beginning, you're going to need to get them involved to get the claim corrected. Lost charges. Again, lost charges, people have been talking about lost charges forever, and they're always putting things in place to capture those charges and making it easier for the clinical staff to ensure that the charges aren't lost. But incomplete clinical documentation can create some of that issue of inaccurate coding. So you want to make sure that that's appropriate and complete. And it creates incorrect bills, and then you're stuck with lost revenue. And again, you're going to need the clinical resources involved to make sure that if there is something missing, that you're able to recapture it and potentially do a rebill. And that is certainly a costly procedure. And there must be meaningful dialogue between the clinicians and the revenue cycle to make sure that this is it's going to improve. Just as getting case management involved in the pre-admission, you want to, and usually they are today, this is not completely new, that they're involved in the admitted patient. And when they are involved with the admitted patient, you want to make sure, again, that communication exists. Case management is going to be involved in helping to minimize and manage length of stay and minimize any subsequent denials. And this is, billing is going to be impacted by length of stay and the denials. Clinical resources are needed to receive payment, and they also need to be involved from a medical necessity perspective. And again, make sure you're not only documenting the care that was provided, but what the patient outcomes were. And finally, discharge planning, and certainly now more than ever with the new conditions of participation that just came out. So case management does the discharge planning as it is today. They manage the length of stay. They're going to avoid readmissions and also organize and plan for the patient care post-discharge. So with the new regulations that came out, they were put in place by the Trump administration they were designed purely to empower the patient to be involved in their care planning and the decision-making of their discharge plans. It used to be in the past, maybe they would get one home health agency that they should go to, or maybe a couple SNFs and they could make that decision, but they really didn't quite understand the various opportunities that were out there and make sure that they understood the level of care that they were going to be getting. And it's really a big step toward providing patients with the power to make their own decisions. And as part of that, they're also required to have access to the electronic medical record, should it exist. And if the medical record is not electronic, then they must have the ability to get copies of their medical record at the time of discharge, so again, they can understand what their treatment plan is. What it was designed to do is take this decision that was mostly opaque for the patient and shed a lot of light on it and make it a clear decision, and again, to keep the patient and the family members involved. And any type of improper documentation as it relates to the discharge planning, it's going to create billing and reimbursement errors. Again, going back to the discharge status code, it significantly impacts reimbursement due to the transfer DRG rule. When you think about patients that are readmitted, readmissions not necessarily impact the reimbursement today, but they impact reimbursement for several years to come. So again, you want to make sure that the post-acute care plan is appropriate and make sure that patients are not readmitted. Consumerism. When you think about the literal definition of consumerism, the theory that an increase in consumption of goods is economically desirable. Well, I'm not sure that applies in healthcare. I don't necessarily think that people like to consume more and more healthcare. But when you think about the second literal definition of it, the promotion of the consumer's interest, that certainly applies to healthcare. And at the core of it, it is about patient satisfaction. And from a healthcare perspective and a provider, we need to be focused on patient consumerism and on their interest in their outcomes, and make sure that there is patient satisfaction. So in order to have consumerism, there must be a clinical focus on patient experience in order for that overall patient experience to be a positive one. Revenue cycle must constantly look to improve the overall experience. And then in order for there to be complete consumerism, it is dependent on both the clinical outcome and the revenue cycle. And I'll use, two opposite examples. If a patient has positive patient outcomes and they receive their treatment and they go home and they recover, but then in a month and a half from now, or 2 months or 3 months, they receive a bill for $5,000 and they were not expecting anything, they forget how good their care was and it doesn't matter to them, and then that consumerism is gone. On the flip side, God forbid something were to go wrong clinically with that patient and their recovery was lengthy and there was an infection and they had to have continued care, and we didn't ever bill them for that. We wrote that off. They don't care about that either. So again, it's important to think about the both clinical outcome being positive and the revenue cycle experience for them be positive in order for that complete consumerism to occur. And now Meliza is going to talk about the revenue cycle impact on case management.
Okay, so now hearing everything so far that's been discussed, case management is basically faced with a lot, and should we say a plethora of healthcare changes. The complexity, the details, the intensity of utilization management that's required, the criteria that they have to remember, the levels of review, the appeals, and I can go on and on with that. So I'm going to start with one of the major impacts that revenue cycle has on case management is the payer and the health plan contracting requirements. Again, I'm going to ask this question to Mary. Mary, back in the days when you're in revenue cycle, how often do you involve or notify case management about changes that have occurred or is about to occur or that's being discussed with the contract?
It's such a valid point, Meliza. We never, ever reviewed it with case management. We only looked at it from a financial perspective and making sure that we billed it appropriately and that we reflected the reimbursement that we were expecting on the account, but never did we look at it from a case management perspective on how they could carry that out.
And so that's how that is an impact, because no matter what comes out of that contract, it is going to affect the workflow and the process of case management. With the contracts, I remember there's multiple guidelines, there's criteria. Are we supposed to follow are we supposed to follow interqual or minimum care guidelines? Are we using clinical or evidence-based guidelines? You have to remember the times of submissions. Are we submitting it multiple times? Are we only submitting it at the beginning, in the middle, at the end? And then there's also the methods of review on submission. Before, back in the day, you used to do it via fax. And then now there's secure email, now there's portals, there's various ways of how to submit it. But again, we have to make sure that we follow what's in the contract, because it's easily said, oh, we submitted via fax, and they can say, we never got it, denied. So that's one of the things that you don't want to get those issues from a technical aspect because of logistics. And then also I know that on weekends and holidays, different phone numbers changes, who to call, who to contact. If you're in a level 1 appeal and you still get denied, are you able to get in contact with a level 2 appeal? Can you talk to a supervisor? So those need to be taken into account when discussing contracts, because it will affect the workflow that case management and utilization management are going to be working on. Now, as far as hospital utilization management, there are some impacts there, the billing requirements like Mary mentioned. We need to know all the W's, I would say, about documentation. The whens, the whats, the wheres, the whys, and the 1H, how. It's going to affect how it's going to be coded. It's going to affect how it's going to be reimbursed. Mary mentioned about, is it going to be an observation? Is it going to be an outpatient? Was it an inpatient? If it was an inpatient, you turn into observation. Which condition code are you applying to it? Everything is going to affect your reimbursement. The reviews, the type of reviews, are we doing the review before the service is going to be provided? Do you need to get a certification before you get that admission or scheduled in? Do you do a concurrent review while it's happening? And then the retrospective review, that's the one thing that's a little bit difficult to accomplish, because when you do a review right after the fact, again, as Mary puts it, if it's not documented, it's not done. So if it's denied, it's very hard to appeal a case where you don't have the documentation and how you're going to do the review on that one. So again, it will affect your appeals and your denials management. So we need to take that into account at the beginning. Another part of hospitalization utilization management that's impacting case management and revenue cycle. Revenue cycle has data. They have oodles and oodles, should we say, of data. They have the data trends. Now, it's not going to do anybody any good if the data and the trends is only staying with revenue cycle. Case management needs to be aware about that data and what trends, so they can work on streamlining their process or work with the clinicians and the physicians on how we can improve any of those trends, working on denials, the length of stay. And then the one thing I think everybody's familiar with is audits. Audits is out there. Everybody goes through audits right now. And I think it would be nice if you are able to mitigate before those audits comes and that you're prepared for it. One thing that I want to mention is the PEP report. I put it under audit, but it's not really an audit. It's basically an electronic report that provides Medicare data specifics for discharges and services that are vulnerable to improper payments. Now, it basically cannot be used to identify the presence of payment errors, but it can be used as a guide. It helps yourself to understand where there is a possibility of improper payments. Now, they send those PEP reports to facilities, to short-term hospitals, long-term hospitals, hospices, any facilities, inpatients, home health agencies. Now, I know the ones that are doing the audits, like your MACs and your RACs, they're not provided with PEPers. However, I will let you know that they can generate it for providers in their jurisdiction and regions. And so it would make sense for you to actually be familiar with that PEP report, because if they are going to be doing their audits and they are able to generate that report, they know exactly what they're going to look for, okay? And the other thing that if you take a look at CMS website, they do mention in their educational profile about the PEP report. So to me, if it's in their website and it's in their education, there's a reason why they put it there. It's for all of us to take availability of the education that they're providing on what they're using. I think we want to know what the benefits of aligning case management with revenue cycle is, because I think that's the reason why we're here, and I think Mary's going to talk more about that.
Yep, absolutely. So why should a provider go through the trouble? And, you know, if you decide to take this under, it certainly is going to be a big undertaking, and, you know, you should know why you're heading in that direction. So from an organizational change, it really is financial and clinical revenue cycle functions are 100% going to be aligned. So starting with patient access and that patient scheduling, patient financial services, so when you're clearing that patient to be covered and you're getting the claim billed, revenue integrity, care management, clinical documentation, medical records coding, and transcription. It really creates a system-wide revenue cycle focus. It is aligning everything that impacts the bill and payment. So the transformed revenue cycle, and it would be transformed, there would be the foundation of patient access. And from a patient access perspective, it would not be just making sure the patient gets on the schedule and that we confirm that they have insurance, but there would be a clinical and financial clearance that went hand in hand, and it would make sure that the patient is being scheduled at the appropriate level of care. Maybe there's something about their care that's usually done on an outpatient basis, but it really should be on an inpatient basis. So you're not just looking for demographics and insurance coverage, but it's really there's clinical involvement. And you also want to make sure that the patient understands what their piece of that claim is going to be, whether it be $50 or it be $5,000, but that communication needs to occur. And then there's that critical middle with case management being involved in the patient while they're in-house in utilization review, and clinical documentation is being reviewed concurrently. So you're going to decrease days, prevent delay in care, and prevent denials. And then there's that strong ending or the grand finale, billing, contract management, denial management, and payment posting. And it all happens easily because everything's appropriately coded and appropriately billed, and there's absolutely no need for a collection process. And that's the ultimate success, that claims are not on your AR for 120 days while you're trying to appeal a day, or it's not billed inappropriately, and now you got to get the claim corrected and try and track down that money. And we're really focused on the increased cash flow. And when you think about your revenue cycle, it means something completely different when you say the revenue cycle. So there's a greater understanding of the full revenue cycle and all those pieces that I listed several pages back. Your communication increased. Your financial goals are aligned as it relates to both the clinical areas as well as your true financial revenue cycle. And then ultimately there's going to be decreased denials, which is what's going to increase that cash flow. Diving into the decreased denials just a little bit. So again, case management is going to begin at time of scheduling. Patient access occurs with positive patient outcomes as a common goal. So when you go through patient access, what you already have their patient, what is the patient outcome in mind when you're getting that patient on that schedule and getting them set up. Utilization management is going to be involved at the beginning, so there's proper resource consumption. Again, so they're receiving the appropriate level of treatment and care that they should for the diagnoses that they're presenting with. The clinical documentation is complete, and it's complete prior to that claim going out. And again, the billing is accurate. And Meliza, if you could talk a little bit about the better patient outcomes, that would be great.
Yeah, you know what? We've talked a lot about revenue cycle. So today's revenue cycle, if you already know, have access to a lot of data, a lot of information. They have the information technology that can help assist with managing the length of stay, appropriate allocate resources, and prevent denials, ensure accurate documentation for coding and appeals. You know, armed with the knowledge of payer and health plan intricacy, which revenue cycle is very well aware of, we can bridge that gap between quality care, clinical necessity, the intensity of services, as well as the coverage and reimbursement. We significantly can decrease the length of stay and manage appropriate use of resources and services, like I've mentioned. And the one big thing is preventing that denial. We want to ensure that we have the coverage. We always say coverage from day one. How about starting the coverage before day one even start, making sure that you are going to get something, and then ensure that there's proper documentation.
And I think what's most important when we review that slide is that Meliza and I are really saying the same thing. We're just coming at it from different perspectives about, you know, denial reduction and increased cash flow. And it just lends itself to the need to blend the two worlds.
Now, as far as operational efficiency, it's not just in revenue cycle. We want to make sure that case management and utilization review should be involved in any quality assurance, any quality improvement or performance improvement activities, however you define it in your organization. It helps evaluate patient care systems that include standards, your protocols, your documentation for efficiency. Again, admissions and registration. Is it prudent to have case management in the emergency room? We don't know. It depends. It depends on your organization if it's ready for you to have a case management in the emergency room, because I think having case management at the front end can lend some assistance to the knowledge that they have and get it right the first time, and you're not backpedaling to fix it after everything is already said and done. You can ensure proper documentation, and you will improve your reimbursement, as well as starting the navigation of the patient from the beginning all the way up until the end. And then I think the next slide is the favorite slide, I think, of Mary and I. We love this slide. It's about accountability. There's no more single point of accountability, and if we were doing this live, you'll probably see Mary making gestures of there's no more finger pointing. Gone are the days where you sit in the meeting and you look at the results and you're saying, okay, how come case management didn't do it this way, or how come it wasn't coded correctly this way, and why didn't we get it right the first time? You eliminate the silos. Revenue integrity, working together with case management and health information and patient financial services are not left in the dark, just looking at the results at the end.
Yep, again, you know, There's a single point of accountability, and we're all trying to get to the same place.
So now Mary, I think, is going to give us some recommendations.
Absolutely. So now that you have all this information, what are you going to do with it? So the alignment approach. If this is something that you think that you wanted to do, you wanted to create that new revenue cycle, you got to make sure that there's executive commitment. You have to select the appropriate team members, and there needs to be individual involved in all steps of that revenue cycle. It can't be just financial people. It can't be just clinical people, and it can't be just directors. You need to have all levels involved so that you can understand exactly what happens and how to best meld the two departments so that the patient consumerism is the #1 goal. You want to develop strategic objectives. So what does the end look like? How far do you want to go in combining those two worlds? What are the goals that you have? And continuing on with the alignment approach, you want to look at your organizational assessment. You've got to step back and look at do you have the appropriate resources to be involved in this type of change? Is this the right time? Maybe you're going through a huge computer conversion or bringing in a new computer system, and it doesn't make sense because people are so focused on getting that right. Maybe you're building a new facility and it isn't the time to do it, or maybe you're building a new facility and it is the exact time to do it. So when you go into that new building, you have that new revenue cycle, and patient consumerism is your #1 outlook. And is there a need for drastic change? Maybe you don't get many denials. Maybe there's great communication between your revenue cycle and your clinical areas, and there's no reason to bring them under one aligned structure. And then project plan execution. This, of course, is critical. You want to have a well-layered plan, and you want to, it's got to be focused on resources. So from a revenue cycle perspective, you need to educate case management. You need to make sure that there's value-based contract terms and that case management understands them. And if there's required technology use, if there's some place that they should be putting their case management notes so everybody can see them, you got to make sure that they understand that. You want to align case management and revenue cycle. From a goals perspective, you want to make sure that everybody has best practices that has the end result in mind, and you want to create mutual benefits. And you should always have budget neutral support. So realign revenue cycle employees. Consider where employees are most needed, and maybe it makes sense that somebody in the patient access department is sitting in the case management office, or vice versa. And maybe there's a case manager who's not only reaching out and talking to the insurance about the coverage of it, but they're also talking to the patient about their coverage. So again, looking to align some of your resources so that you get the support that is most needed. You want to have certainly a focus on denial reduction. You want to maintain denial-related KPIs so you understand if your new structure is working or not. You want to educate everybody on the denials when they come in, and then always involve utilization management, and then hopefully you're going to have some increased cash flows by the end of it as a common goal. Data sharing should certainly, as Meliza mentioned earlier, should occur, and there needs to be strong communication around this. Financial data should be shared with case management and utilization management. You should meet regularly to review the contracts, communicate any changes. So again, case management understands what they need to do, and then case management can communicate back what the challenges of that communication is or the changes, and then make sure it gets negotiated into your next contract so you're not faced with the same difficulties that you're having with this current contract. And then some improvement areas that you should have measuring in your data sharing is your cost per case, the length of stay, and then again, denials.
And then some takeaway from case management. I think we all know case management does support cost containment, not just on a clinical aspect, but as well as the cost containment point of it. You know, when it comes to pre-admissions and admission certification, getting it done at the first time before they even hit the door, doing all those reviews. Again, are we doing it before the care is being provided, during and after, and then being involved in discharge planning from day one. Involve the whole team, physicians, nursing, social work. I mean, we would like to say case manager is the captain of the ship, but it's always been the physician. But however, case manager kind of holds it together. You know, they basically know what's going on from a physician point of view, what the physician is thinking, where he's going with that care, and then tying it with social work and pharmacy, respiratory, physical therapy, your occupational therapy. They also help enhance operational efficiency. They work together closely with the healthcare team, whether it be the interdisciplinary team, which is basically what we've talked about, physicians, social works, physical therapy, but also the interdisciplinary team. These are your nurses and your caregivers that's in, let's say, the critical ICU area, and that when the patient moves into the telemetry area, those plan of care is being communicated from the care team in ICU to the care team in the telemetry to the care team in med-surg. So then when the patient is ultimately discharged, they have an idea of where they're going with this patient and what they're doing. And then the documentation is in place. Involve the post-acute discharge facilities. You have to get them involved from day one, because you know what? If they're holding a bed from day one, that's good. But then if the bed's given away, now you're starting fresh. And if the patient's ready for discharge and you're waiting on a bed, that's going to be a denied day. So just make sure that they're involved from day one. And then the transport. I think a lot of people forget about the transport team. Sometimes you have everything all set and done, and then you realize, oh, we need to get transport, and then there's no transport available till the next day. So again, you got a patient sitting there waiting for a transport, and it's not available till the next day. You know you're going to get denied that day. So get them involved from the beginning. And then the quality department, the risk and compliance, they have information that ultimately can be shared and should be shared with case management, because they will affect the results of those. And again, with admissions, registration, and scheduling, be part of that from the beginning. I think we talked about a lot, and I believe Mary has some final advice.
Sure. So just as final parting advice, make sure that everyone has the same goal. It's going to be positive patient outcomes and make money. Even if you're in a not-for-profit, you know, you're here to make money so that you can turn that money back, put it back into the facility and make some additional capital changes or whatever is needed, or buy new equipment. And then finally, you want to make sure that there's you offer support across all functions of the newly designed revenue cycle. Make sure that everybody gets the support that they need. Questions? It doesn't look like there's any questions at this time. I just did want to mention that Bessler we perform transfer DRG reviews, as well as we do IME recoveries. And Bessler, without displacing or disrupting a current revenue vendor or internal process, Bessler's transfer DRG revenue recovery service can provide a secondary validation of impacted claims to ensure you are identifying all potential underpayments. And we have recovered $2.5 billion for our providers. All right, I don't see any questions. Thank you very much for your time. Have a great day.